plus or minus 0.11 versus 0.331 plus or minus 0.14 in cases of aspheric lenses, and with a showed a good statistical difference significance. When we compared the spherical versus enhanced, it was 0.212 plus or minus 0.11, 0.186 plus or minus 0.123, which with a p-value of 0.346, which was almost comparable in that case. So when we checked also the mean total spherical aberrations caused by these lenses, you can see the spherical monofocal, it was 0.34 compared to the enhanced monofocal, which is 0.29. And the internal spherical aberration, the mean values as shown in the table onto your right down. The spherical monofocal lenses, it caused an internal lenticular spherical aberration of plus 0.045, and the aspheric lenses minus 0.042, and enhanced monofocals of 0.056. So we came back to the literature with the studies, with whatever is existing in the literature. So you can see that the randomized, prospective randomized study with spherical aberration and depth of focus in eyes implanted with spherical as well as aspheric lenses that we compared. So in that, the new Technis IHANS ICB100 has a modified anterior optic surface which induces a spherical aberration in order to enhance intermediate vision. And it is expected a higher value of the root mean square for the higher order aberrations in this group compared to the ZZB group. This was almost similar with what we also checked in case of the higher total aberration as well as the internal aberrations. Now another study also which compared a visual and optical quality of enhanced intermediate monofocal versus standard monofocal lenses. The reduction of total spherical aberration after aspheric may degrade a distant corrected near as well as intermediate visual acuity. So to conclude, spherical monofocal intraocular lenses, owing to their inherent spherical aberrations in the central region, they exhibit superior intermediate vision, which are nearly comparable to the enhanced monofocal intraocular lenses, but however, in contrast with the aspheric monofocal intraocular lenses. Now, yes, further studies on this type of asphericity of each intraocular lens, they might give further insight to quantification of the internal spherical aberration as to how much of the root mean square will be a minimal amount to induce those aberrations for a better intermediate vision, and which is required for each type of IOL, like tailoring kind of, and for improvement of the intermediate vision. I would like to thank you, the APAO committee, for giving me this chance, and thanks to our mentor, Dr. Sri Ganesh, and the co-authors of this, Dr. Savio sir, Dr. Datri, Dr. Linto, Dr. Supriya ma'am. Thank you for a patient hearing.
Thank you. So now in your practice as a recommendation, you feel aspheric lenses are actually a disfavor to the patient looking at the intermediate requirement if a patient doesn't opt for EDOF?
Yeah, thank you. Thank you for the question. Yeah, it depends totally on how you customize for the patient and patient requirements, and of course how they can afford to the new things. Now, another thing is we have to consider the corneal parameters, what any other previous refractive procedures are gone on that. So we all are aware about the standard algorithms which we follow, which is already in the literature.
Well, what would be the
Dr.
algorithm
Devgan's-
basis your practice for for a normal cornea, no surgery done?
Yes, it again depends on ma'am how the people can afford for a spherical monocular lenses. Yeah, if there are no other surgeries, then there are other parameters which has to be checked. That is decentration and also the tilting of the IOLs. These all things has to be considered. And I would like to still follow that Dr. Devgan's algorithm tree, which is already in the literature, which will slightly still would fit into those kind of patients. And what are the patient's expectations kind of for the intermediate vision? And of course, how the patients can be able to afford those lenses. So I'll be comparing and then coming to a decision for the intermediate vision.
Okay, thank you.
Thank you so much for a patient hearing. Thank you so much.
Should we move on to the next? Dr. Keki sir will join later. So Rakshit, if you're ready. After Dr. Rakshit, we have Dr. Raghav. Okay.
Next presentation. Rakshit. Rakshit now. Skip out next presentation.
नहीं वो वाला नहीं Sri Ganesh is with Dr. Sri Ganesh.
So good afternoon, everyone. Yeah, sorry about that technical glitch. My name is Rakshit, and I will be presenting the refractive outcomes of toric phakic intraocular lens implantation in keratoconus. I do not have any financial interests. So we do know that among the patients who come in seeking refractive surgery, keratoconus patients make up anywhere between 1 and more than 10%, again, depending on the geographical location and the diagnostic criteria. And we do know that cross-linking, while effective at halting keratoconus progression, the mainstay of visual rehabilitation in these patients is often limited largely to the realm of glasses and contact lenses. Now, while you can do a cross-linking along with the topo-guided photorefractive keratectomy or an intracorneal ring segment implantation, that would facilitate corneal regularization, spectacle independence is never the goal of these procedures. And then enters toric phakic intraocular lens implantation, which is a potential option that could address the keratoconus patient's desire for spectacle independence. So the purpose of our study was to describe the refractive outcomes of toric phakic intraocular lens implantation in stable keratoconus. This was a retrospective case series in which patients underwent either toric ICL or toric IPCL implantation over a 5-year period at our center at Coimbatore. Patients who were included were those with stable keratoconus, either age stabilized or post cross-linking, with a minimum follow-up of 1 year after the surgery. So again, these patients, the way they were selected was if they had good best spectacle corrected vision in a central cone, they were either subject to just a cross-linking or a cross-linking along with topo-guided PRK. And if they had poor best spectacle corrected visual acuity, the cornea was regularized using an intracorneal rig segment along with cross-linking. And we waited for at least 6 months before taking these patients up for toric phakic intraocular lens implantation. So it was an EMR-based retrospective chart review where we got all this data in the post-operative period, and the statistical analysis was by the IBM statistical software. These were the results. There were 126 eyes, roughly equal between the two genders. More than 3/4 had bilateral lens implantation. The mean age was nearly 30 years, and the corrected distance visual acuity was about 2030. And the mean spherical equivalent in this patient group was about 6.5 diopters, and the mean Kmax was about 53.5 diopters. So 3/4 of the patients underwent some form of cross-linking for stabilization. The rest were age stabilized. And the IPCL was used in 62% and the ICL in 38%. The cone was centered in nearly 3/4 of the cases and decentered in the rest. And an astigmatism of more than 4 diopters, 4 or more diopters was seen in 54% of the patients. So the postoperative spherical equivalent was within half a diopters in 80% of the cases and within 1 diopter in 90% of the cases. There was, of course, an improvement when the preoperative corrected vision was compared to the postoperative uncorrected visual acuity. 39% of the patients had a visual gain of 1 or more lines after the surgery that they did not have before the surgery. When we compared specific groups like the ones with low versus high astigmatism, a cutoff of 4 diopters, there seemed to be no difference in the improvement in visual acuity among these two groups. And there were no differences seen again between the ICL and IPCL groups. And there were no statistically significant differences when the visual outcomes of patients with central versus decentered cones were compared. So the results in our study again mirror some of that in literature with similar good results with good visual improvement in these patients post toric phakic intraocular lens implantation. So to conclude, an appropriate case selection is very vital in this patient group, and it is best to only stick with patients who are satisfied with their best spectacle corrected visual acuity. Of course, sizing, as is a bugbear with the phakic intraocular lens procedure in general, does have a few pertinent aspects to discuss with respect to keratoconus, although that data is not in the scope of this study. That's something we're looking into because sizing can often go awry in these cases if we don't take the proper consideration, especially in patients with very high Ks. Again, it's best to avoid this procedure if the patient is used to using specialty contact lenses and is happy using rigid gas permeable or gross K or scleral lenses. It's best to really stay away from this because they are not going to get visual acuity that is going to equal in terms of quality what you will get with a phakic IOL. And it's probably best to stay away with patients who with the best spectacle corrected visual acuity of worse than 612 even after a regularization. And if the patient is simply not happy with the quality of vision with glasses, then you can be fairly certain that this is a patient who is not going to be happy after a toric phakic intraocular lens implantation. I yield the rest of my time. Thank you. Thank you for the opportunity.
I have a question for you. Am I heard?
Yeah, yes, you're audible to me, but probably not to
See,
the.
we tend to go for a one size less in these phakic IOLs. So, do you think by sizing the lens a little smaller, in this series, you had any patient who had a rotation of the lens which needed to be realigned on axis?
We did have some patients. We had 6 patients who had some alignment issues that we need to go and fix on day one. As you mentioned, in terms of the sizing itself causing problems in terms of rotational stability if it was sized too less. This was less seen with us. We had more patients who had a higher vault because the lens was oversized. Possibly in cases with K max of higher than 53, 55, and you could have an artificially higher AC depth that shows up, you might end up ordering a lens that is probably a size higher. And this could be something to consider. There are no guidelines that are written down that you need to undersize by this much, and I think it's just based on experience that or pretty much educated guessing where the lens selection in these patients needs to
Or
be
is
done.
it that the IPCL, ICL, you noticed a difference?
IPCL is said to have a larger, higher mid-peripheral vault. So even a patient with a lower vault, the tendency of the IPCL itself is not to have the optic coming in contact with the crystalline lens or not being too close. With the ICL, you don't have the same kind of design, but we didn't really find differences in terms of vaulting, at least in the patients in our study, and we didn't really follow any specific guidelines to correct for this, except if the patient had a K of higher than 55, we probably undersized by 0.25, but that was arbitrary and not followed for all the patients.
Okay, what was the youngest, what was the age, lowest age of the patient that you
I
did?
think the youngest age was 22,
And the oldest?
was 40.
40. Because the keratoconus anyway stabilizes after about 27, 28
right.
years of age.
That's why in a significant minority of our patients, 1/4, we didn't go ahead with cross-linking, even though at the time the trend was that if you're going to go in for something to correct, you would not want the cornea to shift in power by chance if at all the patient had progression. But later on, we realized that most of this keratoconus just stays quite the same. So it's okay to go ahead and do it even without doing a cross-linking.
And what is your follow-up of those younger patients between 22 to 25?
So
The duration?
this has about 1 to 3 years of data. We're still following up these patients who are coming in. This was a minimum follow-up of 1 year that we have. All these patients are doing well.
Okay, thank you.
Thank you.
And one more question. After cross-linking, why did you keep 1 year time only? You
Yeah,
could
so
have-
what literature describes is actually for stable keratoconus, they say 2 years without any surgical after surgical intervention is to be considered. These guidelines are again arbitrary. So even the 6 to 12 month cutoff that we had, initially we following 9 months, then we brought it down to 6 months. We didn't see any progression that happened after the phakic intraocular lens implantation in these cases. So it is an arbitrary number. It's not based on any studies. And that's how the rest of the studies have done it as well. 6 to 12 months broadly is the period.
Okay, thank you.
Thank you, Rakshit. So, shall I call the next speaker? The next speaker is Dr. Raghav Preetham, and he's going to be talking on sailing against tides, deviating from the Lyra protocol.
Good afternoon, everyone. At the outset, I'd like to thank APO and AIOS for giving me this opportunity. Today, my topic is on sailing against the tides, deviating from the Lyra protocol. I have no financial interest. Why do we need such an approach? Because the Lyra protocol, ALCON, gives you FDA-approved guidelines within which you can do the procedure, beyond which they suggest not to do the procedure. To overcome this problem, we started doing topo-modified refraction, where we try to correct the entire topolizer astigmatism. However, it's not taking into consideration the posterior corneal astigmatism, as a result of which we saw some surprises and axis flip which kept happening. The more accurate way of doing it is using the Foresight's analytical engine, but again it's an additional software you need to have, and when the disparity of astigmatism is greater than 1.25 diopters, again the results have not been that great. So just to try to understand our approach here, Just look at an example of a 21-year-old girl with a refractive error of -4 sphere with -1.25 cylinder. Here the important point to take is the plus 0.3 posterior corneal astigmatism. We did a good topolizer scan. You can see the 3 ticks in the center. And now we got the measured astigmatism as -1.91. So going to the planning station, first we have to optimize for astigmatism, where we take the anterior corneal astigmatism from the topolizer, which is 1.91, subtract it from the posterior corneal astigmatism as acquired from pentacam. So we have an effective new astigmatism, and the topolizer axis is always taken in all the cases. Then we try to adjust for the spherical equivalent. Because now the cylinder has changed, we have to optimize it with the sphere. So this is the modified refraction which we get at the end of step 1. The second step is where we look at the high order aberrations, and you can see that most of the times we see a trefoil or coma present in the periphery of the cornea. So it has to be neutralized when we are doing topo guided corrections. So the amount of corneal ablation it takes is a 5 diopters minus 2 microns, which will come somewhere around 3 microns, which is need to neutralize the peripheral trefoil. So again, optimizing for the high order aberration, 3.3 microns adds a 0.2 diopters of induced myopia on the central cornea. So we again try to neutralize this in the final correction, and the final correction comes to somewhere around 4 diopters with -1.6 cylinder. This is what we did for this patient. And at the end of 3 months, the vision is 6/5. More importantly, if you look at the axial or sagittal curvature, you can see that the astigmatism pattern looks more or less same pre and post operatively. To come to our outcomes, we had 378 eyes with mean age of 24.7, male to female ratio 170 to 207. When we come to outcomes in terms of sphere, cylinder and mean spherical equivalent, all have improved both statistically and clinically. In terms of sheer visual acuity on Lagmar chart, we can see that the vision has improved to 0.03 end of 6 months. And in terms of Snellen chart, 97.55% of the patients had vision 20/20 or better. 30% of these cases improved to vision to 20/16 as well. Efficacy index was 1.5 and safety index of 0.5. We had 2 cases of haze, one resolved with steroids, one needed PTK. Interestingly, we also did a small subgroup analysis where we had 79 eyes which were deviating from the Alkan guidelines, and we were successfully able to do topo guided corrections in them. And we compared this cohort to the entire study, and the results were comparable, and there was no statistical difference between this group when compared to the total group. We also compared our results to the existing literature, and the uncorrected distance visual acuity of around 20/20 or better was seen in 85% of cases or 90% of cases in most of the studies, and we had it close to 97%. And the spherical equivalent was also more or less similar to the existing literature. Some limitations of our study is a small sample size with very specific characteristics. We assumed that the posterior corneal astigmatism is a numerical value instead of a vector. We did not account for lenticular astigmatism. It is a shorter follow-up period, still 1 year, and it has limited external validation. To conclude, we are suggesting an objective and non-machine dependent approach to topo-guided corrections. It addresses the axis flip and posterior corneal astigmatism related queries from the previous approaches. Outcomes are comparable clinically, and the axial curvatures actually try to mirror the preoperative maps, the implications of which are not known at this point of time. Thank you.
Nice presentation. Do you look at the anterior float of the planned ablation to the what is the present defect on the individual's cornea, and do you see whether these two are on alignment in your protocol?
Sorry, ma'am, I didn't get the question.
In a topo guided treatment, what we do is we look on the anterior float map, the kind of ablation pattern which is going to happen to the original defect which is there, and we see whether the two are getting aligned.
Yes, ma'am, we
because
do that. Yes, ma'am. Yeah.
Because sometimes by correcting for posterior corneal astigmatism, internal astigmatism, you should not end up over-correcting. These are eyes which have come for refractive surgery, no? So
Yes.
you should not induce some kind of a myopic or a hyperopic shift.
Absolutely,
So-
ma'am. So we did look into the map while we are correcting it. Like when you said when you are doing the planning, just before going ahead with the surgery. We try to get the circle of least diffusion to the center. And in all our cases, it was also being done and the center of least diffusion was in the center. Where it was pulled, even in the image I showed you, the center was shifted towards the trefoil. We brought it back to the center and it was round in the center in most of our cases.
Do you think it's more theoretical than practical? All these, whether it is the other or the other
So
protocol?
at this point of time, we don't have so many ways to assess the exact quality of how the patient reads. Probably the vision is still 6/6 in most of the patients, but the difference might be the contrast, which might be better in the evenings, or dim light awareness, or the amount of contrast sensitivity they have, or the amount of glare they are facing. Probably those are much finer but difficult things to assess in these patients.
Thank you.
Thank you.
Would you want to call the next speaker? Yeah, Dr. Himani. Dr. Himani will be talking about long-term changes following the ICL.
Is it Himani? The Sonu Goel is over?
Dr. Sonu Goel presented in the beginning.
Oh, okay. Ah. No, it's not fair. Let's see.
A very good afternoon, esteemed judges and my dear colleagues. So I am here to present a very interesting paper on Indian eyes, which is the long-term wall changes following ICL V4C. So what was our research question? We found that Chinese adults had a smaller antechamber angle and antechamber volume as compared to Malaysians and Indians. And also we are totally relying on the data given by the Chinese population or the Western population to assess the wall changes in Indian eyes. So our aim was to assess the wall changes over a period of 1 year following ICL V4C implantation for myopia and astigmatism, and also assess the factors associated with the long-term wall changes. So we did a retrospective observational study for 1 year in 154 eyes from 77 patients and included myopia and astigmatism with all the parameters within normal limit and excluded those with hyperopia, any oculopathology, and patients who had loss to follow-up. So we calculated the pre-op white to white with calipers done by a single observer. The corneal curvature, pachymetry, and antechamber depth were measured with pentacam. The ICL power and size were calculated using the STAR surgical software, and the implantation was done through a 3.2 mm incision by a single surgeon. We assessed the lens vault values using AIOS2025-Free on day 1, 1 month, 3 months, 6 months, and 1 year. And then we divided them into 3 groups based on the vault values of day 1 in less than 250 microns, 250 to 750 microns, and more than 750 microns. This is how we calculated the ICL size and power with the preoperative data. We did the statistical analysis using the SPSS 25 version software and the following tests. And we found out of 154 eyes, 101 eyes were females and 53 eyes were males, and 148 eyes underwent toric ICL. This was the mean preoperative data which we found. On assessing the mean wall changes, we found a decline, significant decline from the baseline, especially during 3 months and 6 months, which was significant in each visit in each subgroup from the baseline. On assessing the 3 groups, we found a spherical equivalent and anterior chamber depth to be significant in amongst the 3 groups, with 22 eyes in group 1, 120 eyes in group 2, and 12 eyes in group 3. On assessing the group-wise mean vault values, we found a significant increase in the low vault values at 1 month and a decrease in the group 2 and group 3 values. We also found significant correlation of white to white and K1, K2 with the vault decrease. The white to white showed negative correlation. That is, larger the white to white, lower is the vault decrease. And corneal curvature showed positive correlation, which means steeper the cornea, higher is the vault decrease. The BCVA, IOP, and endothelial count had no significance. We also encountered a few complications like cataract in 2 cases, retinal detachment in 1 case, low vault less than 100 microns in 2 cases, high vault more than 1300 microns in 1 case, traumatic ICL subluxation in 1 case, spontaneous toric ICL rotation in 2 cases, and steroid-induced glaucoma in 2 cases. So a similar study done in Chinese eyes shows a wall decline at 6 months, whereas our study, which is the first study in Indian eyes, shows a wall decline in 3 months. And also our vault was like comparatively lower as compared to the Chinese eyes. In the same study, group 1 showed a decrease in Chinese eyes, and our study showed a significant increase in the low vault cases. a meta-analysis study shows no correlation of corneal curvature with the wall decrease, but our study shows a positive correlation with the wall decrease in Indian eyes. So on digging further, we found that steep cornea has low white to white, low antechamber depth and antechamber volume. So that correlated with our study that steeper cornea has higher reduction in wall values from the baseline. The Chinese eyes had also a fallacy that they use pentacam to measure the lens vault, but which causes the underestimation of vault values. But our study used intersegment OCT, which is the gold standard. So to conclude, low vault, especially 150 to 250 microns, increases in vault height at till 1 month, but they tend to remain less than 250 microns at the end of 1 year. And similarly, high vault decreases in vault height till 3 months, but they tend to remain more than 750 microns even after 1 year. So we need to closely monitor both these cases and timely intervene and to prevent complications. And the most important conclusion which I would like to say is that steep cornea has much more significant vault decrease over time. So careful monitoring and preoperative ICL size adjustment is very important. So a few limitations like this was a small subset of eyes in Indian population done in small like Eastern India. We need to do further tests, and prospective analysis of these tests is also important. These are some of my references, and thank you.
Nice paper, because it's very important. There's a very important point she's brought out, that if we all of us start measuring the wall size, we will understand that there is some variation which is occurring, because there are variations in the white to white measure done by the technician, and which is why now UBM measurements have started gaining greater footage, although we don't have those advanced machines in our country. But having said that, in your opinion, like we realize that if it's a high vault, there's more likelihood of angle getting closed and all that. So is it better to err towards a low vault, because a low vault doesn't get too low? Would you believe that? Supposing there are two white to whites which are a little different. So would you err to a lower vault, or would you err to a higher vault?
So, ma'am, since our study, we had higher number of lower vault as compared to higher vault. So, the 12 eyes of higher vault did not have any increase in IOP in our study. So, higher vault can always be assessed, and also they tend to get lower at 3 months. So, we can wait and watch at least till 3 months if they are not having any other complications.
Yeah.
Did you measure the angles in any of these patients with the higher volts?
No, if she is asking, she's asking you.
Yes.
If there's a high vault, would you do a gonioscopy to know whether the angle is getting narrower and getting
Yes, of course,
compromised?
sir. Yes, sir.
Huh? You
Yes,
are
sir.
doing-
And still the IOP did not rise?
No, sir. The IOP did not rise.
Central hole.
Because the antechamber depth in those
The
cases
central
are
hole.
already considerably higher than that of the low vault cases.
Why did not it rise? Because of the central hole?
No, so I think the overall angle pre-op itself is very
No,
big.
they were in that small subset of patients, maybe the
The
angles were
antechamber
widely
depth was
open.
already higher in those
Angles were
subset of
widely
patients.
open, and the measurements were not so off. Measurements were just slightly off, so little higher vault did not matter much. Thank you.
Did the vault size have anything to do with the refractive error of the patient?
No, sir.
High myopes, low myopes?
The spherical equivalent?
Yes.
Yes, sir. The spherical equivalent was significant amongst the three groups. The higher vault group had higher myopic power in their eyes.
Okay.
Call the next speaker.
Thank you.
Dr. Ankita Gupta?
Good afternoon, everyone. Good afternoon, everyone. I'm presenting my free paper on comparative analysis of new IRPA calculation methods after Myopic Classic. No financial disclosures. With the introduction of refractive procedures like Classic and PRK, Many patients underwent the procedure to be spectacle independent. Today, many of the post-LASIK surgery patients are reaching at an age at which they'll develop senile cataractus changes. ILPAR calculation in post-myopic LASIK patients using standard formulae like SRKT, Hoffer, Holiday frequently results in undercorrection and thus a hyperopic surprise in myopic surgery patients and a myopic surprise in hyperopic LASIK surgery patients. So why does this error occurs? Because after myopic LASIK, the anterior surface of the cornea basically becomes flat, and the conventional keratometer and the topographers provide incorrect corneal power values and tend to overestimate the corneal power. And also, there is error in the ELP determination, and hence the underestimation of ILPAR is there. There are several approaches have been given to correct these errors using the previous refractive surgery data, and current corneal measurements, and using no prior data. Since at the time of cataract surgery, no prior data is usually available, hence in majority of the cases, the purpose of the present study was to compare the accuracy of ILPAR calculation methods in post-myopic LASIK surgery patients using AS-CRS ILPAR calculator. It was a retrospective comparative case series done in 20 eyes of previously undergone myopic LASIK. It was done using cataract surgery. Inclusion criteria was cataract surgery done using temporal clear corneal incision with phaco with accuracy of IL implantation. All eyes with corneal opacity and intraop complications both of LASIK or cataract surgery were excluded. Basically, parameters of ILPAR, post-LASIK, K1, K2 using topography, true net power use at 4 mm using pentacam, axial length, ACD lens thickness, white to white using IL master had been input into the ASCRS ILPAR calculator, and the ILPAR calculated through the methods using Sharma's, Hage's, Potvin pentacam, and Barrett's true Kino history had been computed, and the average of the all four methods had been computed, and the average ILPA was imputed by the surgeon. Stable manifest refraction at the spectacle plane after refractive surgery was obtained at 1 month postoperatively. And calculation of refractive prediction error was taken into consideration with 0.7 diopter of refractive error at spectacle plane, causing 1 diopter of IL prediction error. Main outcome measures at for each method were mean, median numerical error, mean absolute error, percentage of eyes within 0.5 and 1 diopter from the target refraction. Statistical analysis was done using Kruskal-Wallis test. Coming to the result, mean age of the patient was 47 years and axial length ranged from 24 mm to 32. And the least refractive prediction error was in Barrett's, although there was no statistical difference in mean, median, and mean absolute error in Sharma's, Hage's, and Potvin and Barrett's. Though a hyperopic refractive prediction error was reported by Potvin's Hill formula, other 3 formulas reported a myopic refractive error, though it was not significant. All the 4 methods gave good outcomes with maximum eyes within 0.5 and 1 diopter in Barrett's. The difference was not statistically significant. With very few studies published using no prior data formulas. So we compared with our study with 2 recent studies by Abulafi and Potvin et al. And it was seen that in results of formula by Hage's was similar to our study, while for Sharma's result of formula, it was slightly higher refractive prediction for our study as compared to the other 2 studies. Potvin Hill formula gave a slightly hyperopic error, similar to the Potvin et al. Since the formulas are recent additions, there was no head-to-head comparison between a Potvin Hill formula and Barrett's True K formula, which is basically Potvin Hill formula is basically a formula in which basically cornea measurement of posterior comma measurement is done directly, as compared to Barrett's-Truke, which is measuring using a regression formula, which is done in majority of these studies. And coming to refractive prediction error, the results was maximum were better in the Barrett's-Truke formula as compared to the Abulafia et al. And Potwin-Hill et al. Reported better outcomes in the Potwin-Hill et al. Formula. Limitation of the study was that it was a small size because these cataract surgery patients are gradually increasing because 20 years back they had undergone LASIK. Now gradually they are entering the cataract age, and it was a retrospective design. Strength of the study is that it is comparing the newer ILPA calculation methods, and as discussed earlier, there is no study which is comparing the Barrett's-Truke formula with the Potwin-Hill, which is directly comparing the posterior corneal curvature method. To conclude, all 4 ASCRS methods are comparable. Potwin-Hill method gives a hyperopic shift in contrast with the other 3 methods which give a myopic shift. Thank you. Would like to acknowledge Dr. B.K. Jain sir and Dr. Gautam sir and Dr. Rajendran Khan sir. Thank you. Thank you APAO for giving me opportunity. Thanks a lot. Thank you, sir. Thank you, ma'am.
I don't have any questions. Any questions?
Thank you. Thank you, Dr. Nikita. Dr. Vikas?
Dr. Vikas will be talking on double anterior, single posterior delineation technique to correct plane, dissection plane in smile. So on to you.
Good afternoon, everyone. I am on a mission here to prevent another patient undergoing lenticular misdissection in keratolenticular extraction procedure and landing up with suboptimal outcomes. So I have no financial disclosures to make. So lenticular extraction procedures have become increasingly popular and offer multiple advantages over flap-based procedures. But they do come with their own set of challenges. The most common being for the surgeon to face initial posterior plane dissection and cap lenticular adhesion, resulting in complicated dissection, leading to poor outcomes and headaches for the surgeon. Though multiple signs have been identified previously, but they are not easy to identify for a novice surgeon, especially during surgery for correct plane identification. Conventionally, what most surgeons do is that we want the initial dissection to be in the anterior plane and the second dissection to be in the posterior plane to prevent cap lenticular adhesion. So conventionally, surgeons use one half of the cap edge for delineation of the anterior plane and the other half of the posterior plane. But sometimes this happens in reverse and you tend to land up with trouble with cap lenticular adhesion. So voila, we have our technique which is novel and very safe, effective, very easy to adapt, the double anterior, single posterior delineation technique, and we also described a new release sign along with the technique. So in this technique, we propose that there are 2 areas of anterior lenticule dissection delineation which we do on both the sides of the cap side cut. Here also the maneuver of entering of the dissector is first sideways between the cap and lenticule edge, which is turned curvilinearly inwards towards the anterior plane to get to the anterior plane itself. So after opening the cap side cut, the dissector is entered in between the edges of the lenticule and the cap edge and turned curvilinearly inwards to automatically enter the anterior plane. The same process is repeated on the other side. Since the undersurface of the cap and the anterior lenticule surface are in line with each other, this maneuver ensures that you are doing anterior plane delineation only. When we do the posterior plane delineation, this is done in the central part, the central 1 mm area, and the dissector is entered straight in with slight posterior pressure on the cornea to reach the posterior plane. Now when we do the posterior plane delineation, if you have done anterior delineation correctly on both sides, you will find what is the double stop sign or resistance on both the edges. If you don't find resistance on one of the edges, that means that plane anterior delineation might be in the posterior part itself. After you have noticed the double stop sign, the double stop sign ensures basically that the overlapping areas between the anterior and the posterior plane that you have delineated are correct in all the 3 segments that you have done before. So this helps you in getting a second checkpoint in terms of that you are in the correct plane. And when we do the anterior plane dissection, you can start from any of the sides as you move across to the undissected part and you reach the second already delineated part, there is a sudden release of resistance of the dissector that you can note. This gives you another confirmation that you are in the correct anterior plane only, and you will see here again that how there is a sudden release of resistance because that part was already delineated by you initially. So right here you see the sudden release of the resistance that you feel because you have already delineated that part before. Then the rest of the surgery is proceeded and completed in the usual manner by further completing the anterior dissection and the posterior dissection and taking out the lenticule. But when we do the posterior dissection, because you have only single area of posterior delineation that you had done, you will not notice any release sign here. So this ensures all the correct planes identification at multiple checkpoints. So as a novice surgeon with less than 5 cases of experience, when we did 60 eyes of 30 patients with a wide range of refractive errors, there was not a single case of lenticule misdissection or initial posterior plane dissection in our cases. The advantages of this simple technique is that it is very reproducible, easy to adapt even for beginners. Second, it is equally safe in low myopia patients because this is an area where most surgeons are hesitant because of having difficulty in lenticule dissection. Thirdly, it also gives an opportunity to rescue in case of initial posterior plane dissection because you are likely to have at least one area of anterior delineation still available to you to make an entry to the anterior plane. But the best part about our technique is the multiple checkpoints that it provides to the surgeon. First is the differential entry maneuver for the anterior and posterior plane delineation that we do. Second part is the double stop sign that you check. So this is the second checkpoint that you get, the surgeon gets. And the third checkpoint is when you are doing the anterior dissection and you see the release sign. So disadvantages are that it takes slightly longer time because you do anterior delineation twice. But for a novel beginner surgeons, we would prefer a 3 mm cap side cut, but experienced surgeon can have even 2 mm. But rest assured, following this technique, every patient and the surgeon is going to walk out with a big smile from the OT undertaking any smile procedure.
Thank you. Actually, we still do one anterior and one posterior. I mean, we are amenable to anything. Did you see a distinct difference in all these eyes? Made you feel, no, I should be doing this step only and not the other one at all? Or would you feel, no, this technique, let me put aside for those lenticules which are very thin, where the dissection may be difficult, where the OBL is dense, where this might be one easier step. It need not be done in routine.
So when I started doing this technique, what made me adapt it for every case is that at the center, there are very experienced surgeons as well, but more often than not, once in a while, even an experienced surgeon was landing in initial posterior plane dissection. So that means that there is something wrong that we are doing that even experienced surgeons do land up. They are able to recover from it. They are able to reach the anterior plane, but that leads to a lot of dissection and stromal haze post-operatively that might take longer to recover. So using this technique, and you do this technique only for all keratolenticule extraction procedures, because I never land up with initial posterior plane dissection with this technique because of the multiple checkpoints that I get.
Suppose it works the other way. You have entered the posterior plane first, then
Right.
what?
So you will, first of all, do not get the release sign. So that is one thing. Second, that will only happen if your anterior delineation was also in the posterior plane.
Yeah, that's what I'm asking. You have anterior delineation. You haven't gone in the anterior plane at all. You have entered the posterior plane straight away. As
So
your first
basically,
dissection.
to ensure that that doesn't happen, first of all, you are doing a curvilinear method of entry on both the sides, right? And when you are doing that anterior dissection, and if that would mean that you have all three, you have entered wrongly.
Yeah.
So that is highly unlikely to happen because the maneuver of entry is very different for the anterior plane and the posterior plane. But in that case also, what you will notice is that there will be no release sign, so that should click in your mind that I should stop and reassess whether I am in the right plane or not.
Thank you.
Thank you, thank you.
So we call our next speaker, Dr. Krishna.
Dr. Keki sir was
Dr. Keki.
unable to.
Yeah, yes, you told me, yes.
So,
So Dr. K.
so sir had a parallel session, so we go back to the
bilateral
order.
cataract surgery after myopic lenticule extraction in megalocornea, right? Yes.
there such
has got some of the High Court. So, what is my 62?
Below dot.
Thank
Yeah.
you.
Yeah, that.
Today about in megalo worldwide find any slit lamp showed bilateral megalocornea with distance of 14.8, clear cornea, pachymetry of 413, otherwise the eye being normal. And no published report of refractive surgery in megalocornea done worldwide. This is the first case which I believe we had done. This is the pictures as it shows in the top left hand side, the original topography. The middle shows you the thickness, which is 413 and 410. Measuring the calipers at the side, we did a smile. Maximum capacity 7.5, and this was the result which we got subsequently. He was now comes 2024, life was fine. At that time, he was only a lawyer. Now, he is the assistant public prosecutor by profession, which makes once again the poor doctor now run. He is 6'12", 6'9", he can't manage in the court, and he comes and says he wants to be spectacle free. We explained to him that no one has done it before, and the uncertainty of IOL power, he was willing to take the risks and decided to go ahead. Still, we ran it through the ethics committee to be on the safe side, and we targeted at minus 0.75. We did an IOL power calculation, showed it to be 15 and 18, as you can see from the side. We tried to do a FLAC utilizing the catalyst. However, it refused to accept the curvature. I'll demonstrate it to you in a moment. Had to do a regular routine procedure. Subsequently, we implanted a Rayner lens. The details are at the bottom. This is a short video of the procedure, how it was done. Essentially, you can shut the sound. First, the smile was done in 2019, and then subsequently in 24, the patient returned with a cataract. Flax was attempted. Is unfortunately on a megalocornea, it does not accept it. As you noticed, despite the multiple trials, refused to accept it. It just does not fit. And we then had to do it by a routine. We did our rexus manually and subsequently bisecting the cataract, and we implanted a Rayner lens in the eye. Prior to that, to stabilize the bag, because these are enlarged bags, we put in a capsular tension ring, because it's well known with megalocornea, you tend to get an occasional subluxation. And we put in an EDOF lens, which is the Rayner EDOF lens, which we put. The reason we chose an EDOF Rayner lens is because this is a 12.8 millimeter diameter lens, and it's nice and wide and big, and Rayner lenses are very stable. And as you noticed in the last measurement which was taken, it is 14.8 is the diameter of the cornea. So, bilaterally, 2 days post-procedure, 1 year follow-up, stabilized. IOL power calculation was challenging as no formula was available. But the surgery, the IOL is big enough. We have utilized a Barrett's formula, which has proved to be fairly accurate. IOL has to be big enough to fit this eye. The maximum we could get was the Rayner, which literally worked out well. We put in a capsule tension ring from ring inject from Optech, which is a very soft ring and enables you to get along well enough. In conclusion, it was a bilateral cataract surgery with EDOF post-smile, a unique approach which is there. These are the references we got, including our publication in the Indian Journal of Ophthalmology. Thank you very much for your kind attention.
Thank you, Dr. K.P. Nice presentation.
But since we do expect capsular instability in these eyes, you have put a CTR. But could you have gone a step forward and placed, done a reverse optic capture kind of situation? One question. Second question, with the possibility of a capsular instability on the table or later on happening too, was it wise to place an EDOF lens, that too in a post-refractive surgery?
No, we wanted a Rayner lens. Now, Rayner toric only comes in EDOF. It was not an option we exercised. Rayner torics don't come in a non-EDOF style, so we have put in EDOF. Now, between you and me, I don't know whether EDOF lenses really work. I mean, I know they have got a big lineup. I am basically a trifocal surgeon, and in my opinion, EDOFs work good for intermediate. EDOF was started when? It was started in Europe because people had wanted to see the cockpit of their cars, the dials of the car. They were unable to see it. There were accidents, and in Europe they made it mandatory that if you don't put in an EDOF lens or a trifocal lens, give in writing as to why you have not done it. So this has become common in Europe, and that's one of the reasons why EDOF lenses came into play. But barring that, nothing else.
Okay, thank you.
Thank you so much
Thank
for accommodating me. I'll just run back to my course.
Thank you. We would call our next.
Just ask him to sign.
Yeah, sir will need to sign. Dr. Keki, sir, we'll need your signature
Just
for
Dr.
the.
Krishna,
Just take it and
Krishnaja
get us.
Mandava. She's going to be talking on accelerated cross-linking for hypoosmolar riboflavin solution in thin cornea.
Good afternoon, everybody. I'm Dr. Krishnaja from Narayan Netralaya. I'm going to talk about accelerated collagen cross-linking with hypoosmolar riboflavin solution in thin keratoconic corneas. I would like to thank my mentor, Dr. Himanshu Matalia, for the opportunity. I don't have any financial disclosure. Keratoconus is a progressive corneal disorder leading to progressive stromal thinning and ectasia, leading to irregular astigmatism and visual impairment. The only treatment to be able to halt the progression of keratoconus is corneal collagen cross-linking. Ultraviolet rays, UV rays, and riboflavin increase the biomechanical and chemical stability of the cornea. However, then corneal thickness below 400 microns is an important risk factor for complications. Apart from modifications in the procedure of corneal collagen cross-linking, various riboflavin solutions have been indicated play a key role in the efficacy of corneal collagen cross-linking. So, collagen cross-linking with hypoosmolar riboflavin is an alternative treatment protocol. So, the purpose of our study was to study the outcomes of accelerated collagen cross-linking 18 milliwatt per centimeter square protocol with hypoosmolar riboflavin solution in keratoconus patients with thin cornea. Once the ethics committee approval was taken, our study was a retrospective study carried out in a single center of Narayan Netralaya in patients with advanced keratoconus of corneal thickness less than 400 microns using EPI of accelerated collagen cross-linking protocol of 18 milliwatt per centimeter square protocol. Study population consists of 54 eyes of 40 patients after taking informed consent. Patients with advanced keratoconus with thinnest corneal pachymetry less than 400 microns with no corneal scarring were included, while patients with any active ocular surface allergy, corneal scarring, and corneal thickness more than 400 microns were excluded. Coming to the pre-op evaluation, once topography was progression was documented using serial topographies. Epithelial mapping was done using AIOS2025-Free and thinking for the individual epithelial and stromal thickness, specular microscopy for endothelial count, and followed by patient counseling and subjecting the patient to the collagen cross-linking. Once epithelial debridement was carried out within 8 to 9 meters of cornea, 0.1% riboflavin with HPMC is instilled every 2 minutes. Then for the first 16 minutes, followed by checking intraoperative pachymetry, followed by selecting UV protocol of 18 milliwatt per centimeter square protocol for 5 minutes. At the every follow-up at 1, 3, 6, 12, and 24 months, best corrected visual acuity was done. Slit lamp examination to see for any corneal scarring or any haze, topography and specular microscopy for an endothelial cell count, and the ASOCT was done. Coming to our results, 54 eyes of 40 keratoconus patients with corneal pachymetry less than 400 microns were carried out. The mean age of the patients at time of ACXL was 22.2 plus or minus 5.1 years. Mean follow-up among patients was 2.5 years with 1.1 years of the range being from 6 months to 3.5 years. 56% of our population were females while 44% were males. Coming to the visual outcomes, there was no statistically significant reduction in the flat keratometry, while the steep keratometry showed statistically significant reduction at 6, 12, and 24 months post-operatively, which lead to increase in the improvement in the best corrected visual acuity at 6, 12, and 24 months. Which also to the significant decrease in post-operative astigmatism. However, the thin corneous pachymetry showed no significant reduction. However, there were no statistically significant change in the specular microscopy, and demarcation line was seen in 62% of patients in our study population. No corneal haze or scarring seen in any of the patients in our study population after corneal collagen cross-linking. Our study with the literature where study conducted by Ozek and all correlated with findings of our study. However, our strengths of our study are to the best of my knowledge, our study is the only study carried out with using 18 milliwatt per centimeter square protocol with hypoosmolar riboflavin in thin keratoconic corneas. So it is decrease in duration of corneal exposure to UV radiation can lead to increased patient comfort, relieve the potential exposure of corneal side effects, delaying the need for corneal transplantation. So various alternative treatments are available, but they have their own limitations. However, in our study, we didn't see any complications or any mutations of hypoosmolar riboflavin using the 18 milliwatt per centimeter square protocol. Hence, ACXL with hypoosmolar riboflavin 18 milliwatt per centimeter square protocol is invaluable and delays need for corneal transplantation. Thank you.
So, just a thought that in the hypoosmolar riboflavin cross-linking, the penetration of the riboflavin may be non-uniform because it's not uniformly thick. So then, demarcation lines, how superficial or how deep they were, did you actually, ideally you should measure it on ASOCT and see.
Yes.
So, you all have seen it on the
yes, ma'am. Yes.
So, did you get a demarcation line which was superficial or decent enough? Deep?
Decent enough, we have.
You should have made note of that also.
Okay.
You said in 60% of the patients you've written, you have seen demarcation line. Were these demarcation lines superficial or were they deep enough? Because then only it makes you feel that the treatment was efficient by doing that, no?
And how long was the soaking time, and when did you start doing the cross-linking? Till what level did the corneal thickness come?
We had soakage time was 16 minutes, sir. Every 2 minutes for 16 minutes, followed by 5 minutes of UVA radiation. So in our study population, we have observed almost 100 microns of swelling once we did 100 on an
Only
average.
5
More than-
minutes of irradiation you did?
Yeah,
You
18
don't-
milliwatt per centimeter
Oh,
square.
18
with,
milliwatt
yeah.
for 5 minutes.
And what was the lowest thickness that was included?
Our lowest thickness was 300 microns.
Okay, thank you. We go on to a last speaker, who's Mukesh Paryani.
We
Where
have
is
to have
he?
Manpreet present after the last speaker, right?
Manpreet is, she's already presented.
No, she has to present again, is what we have been told.
Oh, okay. So Mukesh Paryani is not here? Not here. Okay.
Okay, so Manpreet. No,
You have to wait.
Manpreet can present, no?
No. We have to, don't we have
Okay,
to
okay.
collate our results?
Sure. Manpreet, you can set it up till then if it's not set up. We are not supposed to collate. We are just supposed to add and put in an envelope. Individual.
Oh, we don't have to collate. No, he came and told me something. I don't know where that was.
It says that please sign and put in an
How
envelope.
do we write this? We have to write this. He told me to write this.
How do we pronounce the second?
Do we have anybody from the
Scientific committee.
scientific committee
He
to?
was here that time. He gave me this thing. Ritika,
So we have to write the second.
write this.
How do we write that?
You have to collate.
We have to collate.
Oh, you have to sign.
We will not announce the result.
We won't
just
announce.
Go around and
Okay.
we'll collate.
Okay, sir.
Sir, because it says do not consult your marks with the other candidates, they will collate it, sir. देखो इसका तो हम लिख देंगे, बाकियों का वो लिखेंगे, because उनके पास तो ये है. वैसे करना है ना sir, they will fill it up, because whoever you put in, you have marked here. That is what. Because it says do not consult the other candidates, right?
Come. नीचे लिख दिया ऐसे. आपको मिला है?
A very good afternoon to all of you. So I would be presenting our study on indication, safety and outcomes of circle pattern after small incision lenticule extraction. There are no financial disclosures. So circle pattern, as we all know, converts the original smile cap into a complete flap. So refractive lenticle extraction is the newest in the armamentarium of refractive procedures. And for a long time, it was thought that retreatment is more challenging. So circle gives us an option around it, and the procedure consists of creating a lamellar ring, a side cut, and a junction cut that joins the original cap with the new incision plane to create one larger surface. So the clinical applications are enhancement using excimer laser ablation, removal of a completely retained lenticule, and rescue in case of inadvertent operator errors or suction loss during the last step when you cannot enter a rescue mode and continue from there. Pattern D has been said to be the most optimal with the easiest flap lifting in cases of post-smile retreatment. So we wanted to evaluate the indications, safety, and long-term outcomes of circle pattern of retreatment. It was a prospective interventional study of cases undergoing circle pattern of retreatment after smile over a period of 7 years, conducted at RP Center for Ophthalmic Sciences, AIMS, New Delhi. The primary outcome measures were the uncorrected distance visual acuity. The other outcome measures were percentage of eyes within 0.5 and 1 diopter of refractive target, loss of corrected distance visual acuity assessed at 3 months post-circle treatment. In 7 years, circle pattern was performed in 1.49% cases of smile, 15 out of 1,008 eyes. Circle pattern D was performed in 12 eyes. Of these, 4 had intraoperative cap lenticular adhesion, 8 required retreatment for a spherical equivalent of -1.5 plus -0.78 diopters. 3 had suction loss during cap side cut with completion of laser treatment, in which circle pattern A was used as a rescue mode. Outcomes at 3 months, the uncorrected distance visual acuity was 20/20 or better in 93.3%, 20/40 or better in 100%. No eye lost corrected distance visual acuity, 93.3% were within 0.5 diopters of the refractive target, and all were within 1 diopter. No intraoperative flap lifting difficulties or postoperative flap related complications were observed. So just a case example of a 27-year-old female that underwent both eye smile for minus 5.75 diopters in the right eye, minus 6 with 0.5 still in the left eye. At 2.5 years, there was diminution of vision in the left eye with a manifest refraction of minus 1.5 diopters, 25 diopters sphere and minus 0.5 diopters still was planned for left eye enhancement using a circle pattern. So these were the parameters kept for circle pattern. Just to compare the original smile parameters and the new circle pattern parameters. So the incision in smile is of course superotemporal, and we avoid that for planning a hinge during the circle pattern. The hinge is kept nasal at 180, and the lenticule diameter is going to give you the junction cut diameter as well, because it has to create a seamless interface between the new lamellar ring and the original smile lenticule. The lower and upper depth of the circle pattern is plus minus 15 diopters, and we have kept it 130 and 100 because it was 2.5 years post-op, and though the original cap thickness was 120, with time there is some amount of compaction of the stroma, and AIOS2025 showed that the cap now was around 115 to 110 microns, so we have kept the delta as per that. So the circle pattern was applied. As you can see, there is a circular ablation pattern, and this can be easily lifted, and there is a seamless transition across the flap, and the flap was lifted, excimer laser ablation using MEL. The flap was deposited as in conventional LASIK. To conclude, circle pattern is a useful rescue tool for intraoperative suction loss and management of cap lenticular adhesion during smile, and a safe and efficacious method for post-smile retreatment and enhancement. Pattern D is conventionally used. In addition, pattern A may be used as a rescue tool in cases with suction loss during cap side cut when laser firing is completed. Previous studies, there are only few studies reporting safety and efficacy of circle pattern D, none with circle pattern A. So there are only 2 studies in literature. Thank you for a patient hearing.
So, how often, like, can you say in percentage, how often in a, say 100 eyes or even 1,000 eyes, do you feel that you have needed to go for a circle pattern?
Yes,
You
ma'am.
did 15 out of 1,000
15
eyes.
out of 1,008
Nice.
eyes.
You have
Over 7 years.
Oh, you said that.
Yes,
I
ma'am.
missed that.
Yes,
Oh,
ma'am.
okay. So, any question?
Thank you, sir.
Any comparison with surface ablation instead of?
No, sir. Because we, as it is, do not prefer surface ablation because of the haze that may be associated, and as it is, these are our cases from since when we started doing smile. So the interface haze in the starting case, especially when you have a cap lenticular adhesion, may be more, and we did not want to add the haze that may be associated with surface ablation on top of that.
Do you feel that, see, circle software anyway was an intervention which had to be done? Do you feel like I have personally seen and I've read many articles that if there's a person has had a suction loss and you do the retreatment simultaneously, some of these eyes regress. So similarly, in your, whenever you've done a circle software treatment, did you see a regression in the results?
We did not with our 15 eyes, and I think this works better than LASIK because of this reason, because you're not creating a second interface as well. This is the same original interface, so it works more like a LASIK treatment than having 2 interfaces, one on top of other.
Yes, thank you.
Thank you all for your time today. Thank you.
Thank you very much
do
for
we have
very
somebody?
good attendance for a refractive surgery session. So I think we owe it to the good speakers for having you all stay here. Thank you.
Do we have somebody from the scientific committee for the?
To take this,